Good morning, all. Welcome to 7th webinar series of Gokhale Education Society, Sir Dr. MS Gosavi College of Pharmaceutical Education and Research. We welcome you all on behalf of Gokhale Education Society's Sir Dr. MS Gosavi College of Pharmaceutical Education and Research. Today we have one-day national level webinar on the next era of healthcare, precision, treatment, translational research, and Pharma 4.0, which is organized by Department of Pharmaceutical Chemistry under the aegis of Internal Quality Assurance Cell, IQAC cell at MSG COPR. We are glad to say that we are having total 1,525 registration for this webinar. Before starting with webinar, let me introduce our participants to our Gokhale Education Society. The Gokhale Education Society was established on 19th February 1918 by Principal T.A. Kulkarni, who was the great social worker on occasion of third death anniversary of Namdar Gopal Krishna Gokhale, spiritual guru of Mahatma Gandhi. The society has completed 106 years of meaningful existence and today has more than 140 units spread over 3 zones of Mumbai, Nasik, Thane, Palghar, serving 1.25 lakh students. Previously, Gokhale Education Society was led by late Prin S.B. Pandit, President, and a great visionary and eminent personality, late Sir Dr. M.S. Gosavi, Secretary and Director General, who has rendered invaluable service of 65 years in the field of education. At present, Dr. Mrs. Dipti Deshpande, Secretary, playing a crucial role in overall progression of Gokhale Education Society. Now, a few things about our college. The college has been started in 2012. Presently, college offers colleges and research center offering PhD. College also offer MPharm in 2 different streams, that is pharmaceutics and pharmaceutical quality assurance program with intake of 15 seats each. College also offer BPharm program, which is actually started in 2012, permanently affiliated to Savitribai Phule Pune University with an intake of 100 seats. And also DPharm program, which is affiliated to MSBT Mumbai with an intake of 60 seats. College is accredited by NAC for 5 years from 2023 to 2028. The college has state-of-the-art infrastructure and a huge, lush green surrounding, which provides favorable milieu for the students to grow, not only as a good pharmacist, but as a world-class citizen. The college has an experienced, qualified staff with an academic excellence. The college maintains a tradition of good academic results and organizes various activities, including conference, seminar, student faculty development programs, which is now conducted. Recently, we are conducting this program in next month. Workshop for overall development of students and faculty to bridge the gap of academia and industry. Now about the today's webinar. We have today one-day national webinar on next era of healthcare, precision treatment, translational research, and Pharma 4.0 under the aegis of Internal Quality Assurance Cell at MSG COPR. In this today's webinar, we are having 3 different sessions. First session will be conducted by Miss Ayushi Thakkar, which is our prestigious alumni, and she is doing MS in Pharmacology and Toxicology at St. Joseph University, Philadelphia. She is going to talk on from fluorescence to the phototoxicity, 5 amino levinic acid based photodynamic therapy in cancer diagnosis and treatment. The second session will be conducted at 11:45 by Dr. Deepa Mandli, Associate Professor, Department of Pharmacology, Pune College of Pharmacy, Bharati Vidyapith, Pune. She is going to talk on inflammatory bowel diseases from Pathophysiology, basics to research-driven case study. And lastly, the third session, which is conducted at 1 p.m., will be conducted by Ms. Sarang Daitankar, Deputy Manager Production, Hetero Labs, Labs Limited, Unit 3, Hyderabad. He is going to talk on Industry 4.0, automation in pharma industry. Now, we'll start with the first session. Now, I call upon Dr. Bhandari Madam to give the introduction about the first session, first speaker.
Shall we start? Okay. A very good morning and warm welcome to you all on the for the one-day national level webinar on the next era of healthcare, precision, treatment, translation, research, and pharma 4. I'm Mrs. Deepali Bhandari, Assistant Professor. Welcome today's first speaker, Ms. Ayushi Thakkar, on behalf of Sir Dr. M.S. Gosavi, College of Pharmaceutical Education and Research, Nasik. I would like to introduce our prestigious alumni for this first session, Ms. Ayushi. She will be discussed on the topic from fluorescence to phototoxicity, 5-amino levulinic acid, best photodynamic therapy in cancer diagnosis and treatment. Her educational qualification in Masters in Pharmacology and Toxicology from St. Joseph's University, College of Pharmacy, Philadelphia. She has pursued her B.Pharm from Sir Dr. M.S. Gosavi, College of Pharmaceutical Education and Research, Savitribai Phule, Pune University, Maharashtra, India. Her area of interest, study of cancer pharmacology and translational oncology, cell-based assay development, in vitro pharmacology models, drug-resistant mechanisms, and flow cytometry-based cellular profiling. Her work experience, she graduated in the she graduate research assistant from the St. Joseph's University, College of Pharmacy, Philadelphia. Also, she has pursued the graduate student researchers at St. Joseph University, College of Pharmacy, Philadelphia. Research and academic contributions, she has contributed to the development of translational in vitro pharmacology assays, including the establishment of single cell derived clonal populations and treatment adapted drug resistant models. Also, she has performed flow cytometry based analysis to assess the intracellular drug accumulation and carried out the protein and enzymatic characterization using immunoblotting techniques. Also actively engage in presenting the research data and literature reviews and maintaining the accurate and SOP compliant laboratory documentation. I welcome you, Ayushi. Hand over to you. Ayushi, now over to
Um,
you. You can start your session.
is my screen visible? I'm just presenting.
Yes, yes, it is visible.
Okay, so I'll get started now. So thank you so much, Dr. Mari ma'am and Bhandari ma'am, for the introduction. So today I would be talking about 5-amino levulinic acid mediated photodynamic therapy, or 5-ALA PDT, for the diagnosis and treatment of cancer. So I have been working with this therapy for my research for past 2.5 years, and I'm really happy to discuss this with you all in the upcoming slides. So, to start with some basic introduction about cancer, as we all know, cancer, it's a disease characterized by uncontrolled proliferation of cells. So, in a normal healthy cells, the cell division or the cell cycle is tightly controlled or regulated, wherein the old cells would be replaced by the new cells through the process of cell division, and the old or damaged cells will be subjected to apoptosis, a type of programmed cell death. Also, in a healthy, normal body, the DNA repair system would be intact. So, as soon as there's some kind of a DNA damage, a body will detect that damage, and then the DNA repair system will come into picture and would fix that DNA damage. So, what would happen if this DNA damage is not fixed? So, the lack of DNA repair would lead to mutations, which in turn would disrupt normal growth and division. And over a period of time, accumulation of mutations can turn the normal cells into precancerous cells that in turn would evolve into cancer cells. I'm sorry, there was some kind of a technical glitch, I guess. So, as of now, there are different types of cancer treatment options that are clinically relevant. So, the most common being chemotherapy. There are various classes of drugs belonging to this category, like anti-metabolites like 5-fluorouracil, methotrexate. Then there are topoisomerase inhibitors like irinotecan, topotecan. Then there are DNA alkylating agents like cisplatin. I'm sure we are all familiar with with these classes of drugs. Then there's targeted therapy like monoclonal antibodies, tyrosine kinase inhibitors. Then there's radiation therapy. Then there's immunotherapy like immune checkpoint inhibitors. So the most common example of immunotherapy being pembrolizumab or Keytruda. Then we have surgical resection wherein the tumors can be incised. Then hormone therapy like aromatase inhibitors or androgen deprivation therapy in order to get rid of cancers that depend on hormones for growth. Then we have bone marrow transplantation, because often in case of high dose chemotherapy, the cells in the bone marrow will be damaged, and this in turn would prevent the production of new healthy blood cells. So bone marrow transplantation can be an option in that case.
Ayushi, your screen is not visible.
I guess I'm facing issues with the flow of presentation. Like I'm not able to hit the next slide. I don't know why.
Okay, okay.
Yeah. So I'll
Can you reshare
try.
your
Reshare your screen, Ayushi.
Yeah. Okay, is it visible?
Now it's visible.
Yeah, but the problem is that when I put it on like
Full screen. Is
uh,
there any connectivity problem?
no, my connection seems to be good, but somehow I'm not able to like switch back and forth. Okay, is it fine if I don't present the
Yes,
full
yes.
screen?
Okay, fine. Yes, is it?
Okay, okay, I'll just continue with this.
Okay, it is.
Okay. So now that we discussed some conventional cancer therapeutic option, I'm moving on to a novel cancer treatment called photodynamic therapy or PDT for short. So photodynamic therapy or PDT is a minimally invasive therapeutic procedure, meaning it would selectively target tumor cells while sparing the normal healthy cells. So PDT would include three components: a photosensitizer, which is a molecule or drug that absorbs light and gets activated. Then there's a light of a specific wavelength and molecular oxygen. So throughout the presentation, we are supposed to remember these three components, that is the photosensitizer, light, and molecular oxygen, which is abundantly present in our tissues. So each of this component is individually non-toxic, but when combined will result in the generation of reactive oxygen species, which in turn would initiate tumor cell death. So how does this photodynamic therapy works? So the cancer treatment would initially receive a drug called photosensitizer, either topically, orally, or intravenously, and this is then followed by selective accumulation of photosensitizer at tumor site. Now we all might have this question that why is the photosensitizer selectively accumulating in tumor cells and not in the normal cells? So I would probably address this question in shortly in my upcoming slides. So the cancer patient is first administered with a photosensitizer, then the photosensitizer is allowed to accumulate or concentrate at the tumor site. And once the photosensitizer is at the tumor site, the tumor would be illuminated with light of a specific wavelength. And once this photosensitizer is exposed to light, it will absorb light energy, gets excited and activated. And the excited photosensitizer would then interact with molecular oxygen. As I mentioned, molecular oxygen is abundantly present in the tissues. And this would then lead to generation of reactive oxygen species or ROS that would cause destruction of tumor. So now how is the reactive oxygen species produced? So the schematic here shows the photodynamic reaction or the process of photosensitization. And I guess we all might be familiar with this diagram. This is called as Jablonski diagram or energy level diagram. So when the photosensitizer is initially administered to the patient, it exists in its ground singlet state. So it is inactive. And when this photosensitizer is exposed to light of a specific wavelength, it will absorb photons and then will get excited. So from ground singlet state, it will jump to excited singlet state. In the excited singlet state, the photosensitizer is highly unstable, so it can decay back or jump back to ground singlet state by releasing energy in form of fluorescence, or the excited state photosensitizer might undergo intersystem. So in the excited triplet state, the photosensitizer is stable. And from here, the photosensitizer can either jump back to ground singlet state by releasing energy in form of phosphorescence, or it can undergo two types of reaction, that is type 1 and type 2 reaction. So I would emphasize more on these two reactions in my next slide. So type 1 reaction is an electron transfer where the excited state photosensitizer will transfer an electron to the substrates or biomolecules, most commonly cell membrane, in presence of molecular oxygen. And this in turn will result in the generation of reactive oxygen species like hydroxyl radical, superoxide anion, hydrogen peroxide. So the ROS so the reactive oxygen species, they have high chemical reactivity. So they would cause oxidative damage to lipids, proteins, and DNA in the cancer cells, hence leading to cell death. Whereas on the other hand, the triplet state photosensitizer can transfer energy directly to molecular oxygen, which is abundantly present in the tissue, generating singlet oxygen. So the singlet oxygen is highly reactive, and it can also cause oxidative damage to lipids, proteins, and DNA, initiating cancer cell death. So both type 1 and type 2 reactions can occur simultaneously. But if you ask which reaction is predominant, it's type 2 reaction because it's direct energy transfer to molecular oxygen. So the singlet oxygen produced via type 2 reaction is the primary cytotoxic agent that's responsible for cancer cell death. So moving on to 5-aminolevulinic acid or 5-ALA. So 5-ALA is a prodrug. It's a naturally occurring compound synthesized in the mitochondria. So 5-ALA being the prodrug would undergo intracellular metabolism, preferentially in the mitochondria via heme biosynthesis pathway to produce the active form of drug, which is protoporphyrin 9 or PP9 for short. So 5-ALA, which is the prodrug, is non-fluorescent, whereas PP9 or protoporphyrin 9, which is the active form of drug, has two properties. First is it would exhibit red fluorescence, and second is it acts as a photosensitizer, meaning it can absorb light energy and can get excited. So this is a brief outline of how the heme biosynthesis pathway works and how 5-aminolevulinic acid and protoporphyrin 9, two essential components this therapy, are synthesized. So the pathway begins with acid via condensation of glycine and succinyl-CoA in presence of enzyme ALA synthase. So we all are aware that glycine is a simple amino acid abundantly present in the body, whereas succinyl-CoA is the tricarboxylic acid cycle intermediate. So 5-ALA synthesized in the mitochondria will be exported to the cytoplasm, and then 5-ALA in the cytoplasm will undergo a series of enzymatic reactions to produce coproporphyrinogen 3. Coproporphyrinogen 3 will then be shuttled back into the mitochondria, where again it would undergo some enzymatic reactions to produce the highly essential metabolite of this pathway, which is protoporphyrin 9 or PP9. Now, PP9 can undergo two types of processes. Firstly, it can undergo bioconversion to heme in presence of enzyme ferrochelatase, or FECH for short. So ferrochelatase is the enzyme responsible for inserting ferrous ions in the PP9 in order to convert it into heme. Or it can undergo efflux, or it can be pumped out into the cytosol or extracellular space via the transporter called ABCG2. So in normal cells, the heme biosynthesis pathway is tightly regulated by heme itself, wherein the heme will exert negative feedback by inhibiting the enzyme ALA synthase, which is the rate-limiting enzyme of this pathway. So if heme inhibits ALA synthase, there would be limited endogenous ALA production, and in turn, there would be lower levels of PP9. So the synthesis of 5-ALA is the rate-limiting step. It's a slow step, and it's negatively regulated by heme. So if 5-ALA is administered exogenously, this rate-limiting step would be bypassed, and that would result in the overwhelming of the pathway and excessive production of PP9. So this is what we want, especially in case of tumor cells. We want high PP9 production, so there will be high production of ROS, and then there would be increased cancer cell death. Now addressing this question, why does PP9 selectively accumulate in tumor cells and why not in normal cells? So the answer to this question is that heme biosynthesis is highly altered or dysregulated in tumor cells. So there are various factors that are like altered or dysregulated in tumor cells, but the two important factors being downregulated ferrochelatase. So decreased activity of ferrochelatase will result in decreased conversion of PP9 into heme, and therefore would increase the intracellular PP9 levels. On the other hand, increased enzymatic activity of heme biosynthesis pathway enzyme will result in increased PP9 biosynthesis. So the net result of both the factors would be increased intracellular PP9 levels, and that is what we want. We want more PP9 in tumor cells so that there would be more ROS-mediated damage of cancer cells. So protoporphyrin 9 or PP9, as the name suggests, it suggests it is a porphyrin, and it's a highly lipophilic structure. It has 4 pyrrole rings. It's a highly conjugated ring structure with extensive pi electron system, and that's the reason why it can easily absorb light in the visible spectrum, because it's highly conjugated. So the schematic at the bottom shows the PP9 absorption and emission spectrum. So PP9 has 2 absorption peak. So one is the strong absorption peak in the blue light region, around 4 or 5 nanometer, and that is called as the Soret band. And it has some weak Q bands or weak peaks in the red region, usually around 505, 539, 572, and 630 nanometers. So though PP9 absorption is weak in the red light region, red light is equally important as blue light, and I'll explain this in detail in the following slide. And PP9 usually emits red fluorescence around 630 nanometers. So blue light versus red light for PDT. Now we might end up having question that PP9 tends to absorb both blue light as well as red light. So which light would we prefer for PDT? So both blue light and red light are clinically relevant, and they come with their own advantages and disadvantages. So blue light specifically has a shorter wavelength between 400 to 450 nanometers. So it has less penetration power, and it's mainly used for the treatment of superficial or surface level cancer lesions. Whereas red light, on the other hand, has longer wavelength between 630 to 635 nanometers, and it penetrates deeper, and it's used for the treatment of thicker lesions or deep-seated tumors. So both categories, like either blue light or red light, can be used for photodynamic therapy in clinic. So as we discussed earlier, that PP9, being a photosensitizer, can absorb either blue light and red light. So once the PP9 is exposed to either blue light or red light, it gets excited, and it would either release red fluorescence, and this would serve as a basis for the surgeons to resect the cancer or tumor cells with high precision and accuracy. So the diagram here, especially panel A, shows conventional white light therapy, and if we can see, it's really difficult to discriminate or differentiate between the cancer tissue and the normal tissue. Whereas with 5-ALA PDT, surgeons can easily discriminate the tumor cells because of red fluorescence. So they end up resecting the tumor with high precision and accuracy in comparison to the conventional white light therapy. On the other hand, the excited PP9 can also interact with oxygen to produce reactive oxygen species and singlet oxygen via type 1 and type 2 reactions, as we discussed previously, which in turn would lead to oxidative damage. And the mode of cell death in the cancer cells would be either apoptosis or necrosis. So just to make things clear and easy, 5-ALA PDT can be used for two purposes, or it has dual role. One would be photodynamic diagnosis or detection, followed by resection due to its ability to produce red fluorescence. And secondly, it could be used for photodynamic therapy or for therapeutic purpose due to its ability to generate reactive oxygen species, which in turn will cause tumor cell death. So, as we are now aware that PP9 is primarily synthesized in the mitochondria, it accumulates in the mitochondria. So as soon as PP9 is excited, it will produce ROS, and mitochondria would be the primary organelle that would be subjected to oxidative damage since PP9 is produced in the mitochondria. So mitochondria would act as a central gatekeeper of apoptosis. So the ROS produced by PP9 will actually cause oxidative damage to the mitochondrial outer membrane, leading or causing the loss of mitochondrial outer membrane potential. And as soon as the mitochondrial outer membrane potential is lost, cytochrome C is released, and this cytochrome C in turn will initiate the apoptotic pathway. So I won't get into any details of apoptosis now. So I won't get into the details of apoptosis now, but for time being, we are just supposed to keep in mind that mitochondria is responsible for regulating apoptosis, followed or following 5-ALA PDT. So here are some FDA approved indications of 5-ALA PDT. So initially or primarily in 1999, it was approved as Levulan for PDT of actinic keratosis. So actinic keratosis is a kind of precancerous skin lesion. So it was approved in combination with blue light illumination, following which in 2004, Metvix or methyl ester of 5-ALA was approved again for PDT of actinic keratosis, but this time in combination with red light illumination. Then in 2010, it was approved for photodynamic diagnosis or resection of non-muscle invasive bladder cancer as CISView. In 2016, Amyluse, which is a nano emulsion formulation, was approved again for PDT of actinic keratosis. And then finally, one of the breakthrough approval in 2017 was for fluorescence guided resection of high grade gliomas, and it's mainly sold as Gleolan. So as we can notice, it's 5-ALA has been approved for PDT of actinic keratosis only. It's either in combination with blue light uh, or red light. And we have already discussed that blue light is useful for the treatment of superficial lesions, whereas red light is used for the treatment of deeper lesions or deep seated tumors. But in case of non-muscle invasive bladder cancer and high-grade gliomas, it's only approved for photodynamic diagnosis and resection and not for PDT. So, and that's also in combination with blue light illumination, because often during surgeries, when we illuminate the tumor with blue light, the blue light will serve as a great contrast because the tumors will fluoresce red and the surrounding normal tissue will appear blue. And that's really easy for the surgeons to resect the tumor. Whereas if the surgeons end up using the red light for resection of tumors, the blood is red, the surrounding tissues will appear red. And on top of that, the tumor cells will also fluoresce red. And that would be really difficult for the surgeons to identify those cancerous cells or tissues. So blue light is normally used for diagnosis and resection in clinics. Okay, so moving on to glioblastoma multiforme or GBM. So it's a grade 4 astrocytic tumor. So it's a last stage brain cancer. And the reason why I'm discussing glioblastoma is because my research is heavily based on glioblastoma. So it is the most aggressive and common form of primary brain tumors in adults. It is characterized by highly infiltrative growth, diffuse invasion into the normal brain parenchyma, and it's pretty evident from the schematic here. So in panel A, the tumor mass is restricted to one region, one specific region. But as the time goes by, in panel E, the tumor mass is now spreading to the normal brain parenchyma. So this causes great difficulty for the surgeons to really discriminate between the normal brain parenchyma and the cancerous tissue. And this often results in incomplete resection of tumor, whereby some tumor cells would be left behind, and these residual tumor cells would be responsible for cancer relapse or cancer recurrence. So, so far, the standard therapy for glioblastoma is maximum safe resection, that is surgery, followed by radiotherapy and concomitant chemotherapy with temozolomide. But despite such intensive treatment regimen, the median survival in patients is just 15 to 16 months. So there's a great demand or great need for a therapy which is highly selective and and could and a therapy that could possibly extend the survival or the progression-free survival in patients. So one such therapy that has gained clinical success is 5-ALA induced PP9 fluorescence for the resection of high-grade gliomas. So how this works in the clinic. So the high-grade glioma patient would be administered with 5-ALA or gliolan orally at a dose of 20 mg per k. And then 4 hours prior to administration of 5-ALA, the tumor site will be illuminated with light, specifically blue light. So the reason why the incubation time or the time for like it's 4 hours is because the Cmax or the optimum concentration or that PP9 attains is usually 4 hours. So that's the optimum time for 5-ALA to actually get metabolized to PP9. So the figure on the right shows how PP9 excitation after illumination with blue light produces red fluorescence, preferentially or specifically in the tumor cells, thus improving visualization of brain tumors and helping the surgeons to easily resect these tumors with high accuracy and precision. So this improves, so 5-ALA induced PP9 improves the rate of the rate of gross total resection, wherein the maximum amount or the maximum amount of tumor mass can be resected, and this in turn will improve the progression-free survival as well. So, so far, we know that the clinical success or effectiveness of ALA PDT, it highly depends on the intracellular accumulation of PP9 in the cells, especially in the mitochondria. So higher the intracellular accumulation of PP9, higher would be the ROS-mediated phototoxicity. So despite the clinical success of ALA PDT, it does come with some drawbacks or disadvantages. One such drawback being resistance. So there are various factors involved in resistance. I'll discuss few factors here. I'll not get into much detail again. So the first factor is enhanced PP9 efflux. So as we discussed in my initial slides regarding the heme biosynthesis pathway, so the PP9, which is synthesized in the mitochondria, can be effluxed effectively through ABCD2 transporter, thus reducing intracellular PP9 levels. So ABCD2 is basically, it's an efflux transporter. It's also referred to as a breast cancer resistance protein or BCRP. And it's commonly known to contribute to multi-drug resistance due to its ability to pump out chemotherapeutic drugs, leading to resistance. So it's mainly localized to the plasma membrane and the mitochondrial membrane. And again, it actively pumps out PP9, reducing intracellular PP9 levels, leading to therapy resistance. Again, a reminder, we need high levels of PP9, high levels of intracellular PP9 in the mitochondria to cause ROS-mediated cell damage. So any process that reduces intracellular PP9 levels will lead to resistance to ALA PDT. And one such factor is increased PP9 efflux through ABCD2. So the next factor is enhanced PP9 bioconversion to heme. So again, As discussed, PP9 in the mitochondria will be converted to heme by enzyme ferrochelatase. So increased activity of ferrochelatase will enhance this bioconversion, thus resulting in decreased PP9 accumulation in mitochondria, again leading to resistance and treatment failure. So how do we deal with this resistance, or how do we enhance ALA-PP9 fluorescence? So we can either target PP9 efflux or PP9 bioconversion. So we can either we can either target ABCD2, or we can inhibit ABCD2 mediated PP9 efflux using several ABCD2 inhibitors like fumitrimogen C, KO143, kinase inhibitors like lapatinib, gefitinib, etc. But unfortunately, none of these ABCD2 inhibitors have been FDA approved as for ABCD2 inhibition. The other method by which we can enhance ALA-PP9 fluorescence is by targeting PP9 bioconversion, whereby we can chelate ferrous ions. So the ferrochelatase enzyme cannot insert these ferrous ions in PP9 to produce heme. So the net result again will be increased PP9 accumulation and therefore increased phototoxicity. Then the next factor is PP9 heterogeneity. So normally, or like within the same tumor, there might be some cells with high PP9 accumulation, or there might be some cells with low PP9 accumulation. So the high PP9 accumulating cells have been depicted by this bright red color, whereas low PP9 accumulating cells have been shown by this faint pink color. So as soon as this tumor containing different subpopulations of cells are exposed to 5-ALA PDT, the high PP9 cells would be rendered sensitive to PDT and would be eliminated, leaving behind low PP9 cells. So these low PP9 cells would be resistant to PDT, and this in turn would lead to tumor growth, tumor recurrence, and again leading to treatment failure. So personally, my project or my research thesis, it's based on exploring several mechanisms underlying PP9 heterogeneity. And for that purpose, I have been separating the PP9 high and PP9 low cells, culturing them differently. And then I have been running certain cell-based assays to explore the mechanisms underlying resistance to ALA-PDT. Then that's all I had about theory. So I've spoken about some basics about photodynamic therapy, principle, mechanism of action, and resistance. Now I would like to move to some practical part of the work I do. So my research is heavily based on in vitro cell-based assays. So we normally end up using cell culture for our assays. So in lab, I usually deal with human high-grade glioma cell line called U118s. So we tend to culture these cells in Dulbeco's modified Eagles medium, or DMEM. So DMEM, it's a media. It's a source of nutrients, vitamins, and essential growth factors, glucose, everything that's necessary for the cells to stay alive and healthy. And this media in turn is supplemented with fetal bovine serum. So fetal bovine serum is a main source of growth factors like epidermal growth factors, platelet growth factors that's essential for cell division and expansion. And also there's antibiotics. It's basically a combination of penicillin and streptomycin to prevent microbial growth. And these cells are maintained at 37 degrees Celsius in a humidified incubator with 5% CO2. So this is the actual picture of how I maintain my cells. So this is where I put my incubator where I put my cells. So the pink thing you see here is the DMEM or media, and the cells are basically, they're adherent cells. So they're attached to the bottom of the Petri dish. So whenever we plan our experiment, so we tend to remove this media and then we add trypsin. So trypsin, it causes proteolysis. So it tends to break those adhesion bonds between the cell and the surface, and also between the cells. So the cells can be easily harvested, collected, and could be used for our cell-based assays. Then the light source. So for PDT, at lab level, we tend to use a diode laser system. So this is the setup that we end up using. So so as you all can see, this is the small dark box. So this is where we put our petri dishes or petri plates for PDT, and then from the bottom we release that red light, which is centered at 633 nanometers, in order to perform PDT on the cells. So we would normally pre-treat our cells with 5-ALA, let them incubate for 4 hours because that's optimum for PPN accumulation, and then we'll put our dish under the laser for PDT. And we use red light because, again, it has higher penetration power, so it can penetrate deeper into the cells and can induce phototoxicity. Then I'll discuss few assays that we perform at lab level in our research. So the first assay is cell viability or cytotoxicity assay, and we normally do this to assess PDT response. So we are all familiar with the photodynamic action. PP9 will be excited after PDT, and then it results in production of ROS, and ROS in turn will lead to cell death or cell damage. So in order to assess that percent viability or percent cell death, we use this assay. So we first implant the desired number of cells in a 96 well plate and allow them to grow for a day or 24 hours. And then the following day, we end up treating the 96 well plate with 5-ALA or 5-aminolevulinic acid. So it's not just 5-ALA that we use to treat our cells. We used like several other combination of drugs, like as I mentioned in the previous slide, we end up using ABCD2 inhibitors like KO143. We use ion chelators like deferoxamine to assess treatment-induced cytotoxicity. So we normally incubate with the drug for 4 hours, and then again we'll put this 96 well plate under the laser for PDT. Then following PDT, we'll add LMR blue or resizurin. So LMR blue or resizurin is a blue dye with very low or no fluorescence, and resizurin is only converted or only metabolized to resurufin by viable cells. So viable cells here means normal healthy cells having intact metabolic machinery. So resizurin will be converted to resurufin by normal healthy cells. So as said earlier, resizurin, it's blue in color, it has low fluorescence or no fluorescence, whereas resurufin, on the other hand, has pink fluorescence or with high fluorescence compared to resurufin. So what we do is, after adding this resizurin dye, we will incubate our 96 well plate for 3 hours, and then we'll read our plate using a microplate reader. So the readout for this microplate reader is in terms of fluorescence, because resurufin is fluorescent. So on the right, this is just a picture to show how the concentration dependent effect can be seen in these cells. So with the increase in concentration of drug, the cell viability tends to decrease. So more the pink, more the cell viability or more healthier the cells are. But more the purple or more the blue, more of the cell death or more of the cytotoxicity is occurring. So at low dose of drug, the cells are viable, but as the dose of drug or the concentration of drug increases, now the pink color is turning to purple, meaning the high dose is more cytotoxic. So this is how we interpret our results. So we tend to convert these fluorescence value into percent cell viability or percent cell cytotoxicity. Then, how do we measure intracellular PP9 accumulation? And that's mainly done by flow cytometry. So, this is a setup of experimental setup of flow cytometry. So, this is how it looks. So, the flow cytometer is equipped with excitation lasers and emission detectors. So, our flow cytometer, or the flow cytometer that we use for our research, is equipped with an excitation laser that's centered at 488 nanometer, because that's able to efficiently excite PP9. Then there are four emission detectors: FL1, FL2, FL3, and FL4, and each of these detectors would capture a different color of light. So PP9 specifically, it emits red fluorescence, and this red fluorescence can be detected by the FL3 detector. And that's the reason why the results that appear after like experiments, after such experiments, would be in terms of mean FL3 values. So, how the process goes, again, we'll treat our cells with 5-ALA, or 5-ALA in combination with other drugs that we need to test, followed by 4-hour incubation. And then we tend to collect these cells, and then we resuspend we resuspend these cells in a liquid, normally phosphate buffer saline. And then we would end up reading our samples here. So we place our samples here, and each time the flow cytometer will measure the intracellular fluorescence or accumulation in one cell at a time. So the cells would pass through a blue light laser, and this blue light will excite the PP9. And as soon as the PP9 is excited, it will emit red fluorescence, and this red fluorescence in turn will be detected by the FL3 detectors. And this is how so this is a small piece of data which I took from one of our research papers. This is how we present our intracellular PP9 fluorescence data. We have different combinations, and then we plot PP9 fluorescence or FL3 fluorescence on the y-axis. Then moving on to spectrofluorometry. This is the analytical technique we use for measuring enzyme activity. As discussed in previous slides, there are various enzymes involved in the heme biosynthesis pathway. But for this specific presentation, I'm focusing on ferrochelatase activity, because ferrochelatase is a highly critical enzyme in the heme biosynthesis pathway. So what we simply do is we tend to lyse our cell. So what is lysing? It's nothing but it's breaking down of cells using a lysis buffer. So we lyse our cells manually in order to release the enzyme ferrochelatase, which is mainly localized in the mitochondria. And then these cell lysates containing the ferrochelatase enzyme would be incubated with the substrate PP9, because we are basically trying to mimic the reaction that would normally occur in the cell, like as we saw in heme biosynthesis pathway, that ferrochelatase is responsible for inserting ferrous ions in PP9, and then it will convert PP9 into heme. So here we are releasing ferrochelatase enzyme from the cells manually, and then we are incubating these cell lysates with the substrate PP9. And then we add zinc acetate, which will act as a source of zinc ions. So the ferrochelatase will insert this zinc ions into PP9, forming zinc PP9, a fluorescent product. So we might have this question in our minds, that why zinc instead of iron? Because originally in heme biosynthesis pathway, FECH would insert ferrous ions in PP9 to produce heme. But why are we using zinc in this case? So insertion of iron, that would produce heme. So heme is non-fluorescent, and it's not possible to detect via spectrofluorometry. So using zinc will allow the formation of detectable fluorescent product, that is zinc PP9, right? So zinc PP9 fluorescence is measured using spectrofluorometer, and the amount of zinc PP9 formed is directly proportional to ferrochelatase activity. So more the zinc PP9, more will be the ferrochelatase activity, and lower the zinc PP9 fluorescence, lower will be the ferrochelatase activity. So this helps us determine if ferrochelatase is responsible for resistance to ALA PDT. Then moving on to confocal fluorescence microscopy. So we normally employ this technique to visualize mitochondrial localization of PP9. So again, I'm reiterating that PP9 is synthesized in the mitochondria, and it's highly essential and highly critical that PP9 stays in the mitochondria in order to exert ROS-induced tumor cell death. And now we all are now aware that mitochondria are critical regulators of cell death. So we want more PP9 to accumulate in the mitochondria. So to check whether PP9 is actually localizing in the mitochondria, we use confocal fluorescence microscopy. So how is this mitochondrial co-localization assessed? So we would stain the cells with rhodamine 143. It is a dye that specifically labels mitochondria, and it has green fluorescence as depicted in this figure. So what we'll normally do is that we'll treat our cells with 5-ALA, incubate for 4 hours. So PP9 is produced, and then just few minutes before imaging, we'll add rhodamine in order to label the mitochondria. And this is how the results under confocal fluorescence microscopy looks. So PP9, as we are all aware, would label the cells red, whereas rhodamine will label the mitochondria green. And then we tend to interpret the co-localization in terms of yellow signal. So the red PP9 and the green rhodamine would overlap to produce yellow signal. So more the overlap or higher the overlap or higher the yellow signal indicates that PP9 is localized in the mitochondria. And this in turn means that PDT is effective because now there would be more ROS-induced tumor cell death because of higher localization of PP9 in the mitochondria. Secondly, if the overlap is low or if the yellow signal is low, it indicates that PP9 is possibly effluxed, mainly via ABCD2, and there is lower intracellular PP9 levels in the cell, which in turn is the cause of PDT resistance. Moving on to another assay, which is apoptosis assay, also termed as annexin V propydium iodide assay. So we normally employ this assay for confirming the mode of cell death. So as we have discussed in some of like the previous slides, where apoptosis is the primary mode of cell death. So there are two types of cell death mainly induced by 5-ALA PDT: apoptosis and necrosis. And again, this depends on localization of PP9. So if PP9 is localized to the mitochondria, it will lead to apoptosis. PP9 at the same time is highly lipophilic, so it might pass or it might cross the cell membrane via passive diffusion, and it might stick to other organelles, and it can also cause damage to other nearby organelles, specifically cell membrane. So in case of normal cells, phosphatidylserine, which is a type of phospholipid, is mainly localized to the inner side of the cell membrane. And in case of apoptotic cells, the phosphatidylserine would be translocated to the outer side of the cell membrane. And this phosphatidylserine will selectively bind to annexin V. So just for your knowledge, annexin V and propydium iodide both are different types of dyes, and both would have different functions. So annexin V would specifically bind to phosphatidylserine, indicating apoptotic cells, whereas propydium iodide, on the other hand, would enter the cells only when the cell membrane is compromised. So cell membrane is a hallmark of necrosis, and as I mentioned shortly, that PP9 can also stick to the cell membrane because it can pass the cell membrane through passive diffusion, and then when you apply PDT, the cell membrane will be damaged and the integrity will be lost, and now propydium iodide can easily cross the cell membrane, and then it can bind to DNA because it's a DNA binding dye. So this is how we can assess both apoptotic and necrotic cells. And then after the cells are treated with annexin V and propydium iodide, we tend to analyze these cells using flow cytometry. And this is how we end up interpreting our results in form of 4 quadrants. So the first quadrant here is annexin V negative, PI, annexin V negative and PI negative, indicating that the cells are intact, they are live, or they are viable. The second quadrant is annexin V positive and PI negative, meaning that annexin V is now binding to phosphatidylserine and the cells are in the early apoptotic stage and there's no loss of membrane integrity. Whereas the third quadrant here represents annexin V positive and PI positive. So it's positive for both apoptosis and necrosis, indicating that now annexin V is binding to phosphatidylserine, and at the same time, there's loss of membrane integrity due to which propydium iodide can easily enter the cell and bind to the DNA. Whereas the last quadrant is annexin V negative and PI positive, where the cells are completely necrotic. So the primary mode of cell death is apoptosis, which is then followed by late apoptosis and necrosis. Then moving on to the last technique that I'm discussing today, that's Western blotting. And I'm sure we are all familiar with the principle or working procedure of Western blotting. So again, we tend to lyse our cells to release the proteins from the cells, and then we separate these proteins by size or molecular weight by SDS page or gel electrophoresis for short. And then these separated proteins are transferred from the gel onto a membrane like nitrocellulose or PVDF membrane. And then these membranes are incubated with primary antibodies, which are specific to the protein of interest. Like in this case, our protein of interest is the ABCD2 transporter, or could be the various enzymes in the heme biosynthesis pathway. So we end up using anti-ABCD2 antibodies or any antibody specific for these enzymes, like for example, anti-PBGD antibodies, if we want to detect PBGD in our samples. And then after primary antibody incubation, we'll then add fluorescence labeled secondary antibodies, which would bind to the primary antibody and allow the detection of the protein of interest. So this is just some part of the in vitro cell-based techniques that we use in our lab. So I'm not discussing my research aims or research results today. I would have been happy to discuss that, but due to time constraint, I couldn't. I would be happy to discuss like one of the research papers or like my research results someday. And that's all I have for today. I would end this presentation on a good note. Firstly, I would like to thank my research advisor, Dr. Bin Chen, who has been my greatest support. And I'm really grateful to him for having faith in me and considering me a potential student to carry out his research forward. I would also like to thank St. Joseph's University, Philadelphia College of Pharmacy, Department of Pharmaceutical Sciences for considering me as a potential master's student or master's candidate. Also, I would like to thank our principal, Sir Dr. S.V. Amrutkar, Sir, and Vice Principal, Dr. Prashant Pingre, Sir. Thanks for this opportunity and thanks for having me for this webinar. Then I would like to extend my gratitude to Dr. Dhanashree Mari ma'am and Dr. Shilpa Harak ma'am for reaching out to me and encouraging me to present some part of my research. And then I would like to thank the respected faculty of Sir Dr. M.S. Gosavi College of Pharmaceutical Education and Research. And last but not the least, I would like to thank the audience. Thanks for bearing with me for an hour and listening to me patiently. I hope I made the like 5 ALA PDT simpler for you guys to understand. So thank you. That's all. And I'm now open to addressing any questions, if any.
Thank you so much, Ayushi, for your outstanding work that you have done, and you have presented very well. There are some questions, Ayushi. So we will attend these questions from Ram Chaudhary. The question he asked, okay, how does the intracellular conversion of ALA to the protoporphyrin 9 differ between the normal cells and the cancer cells?
Okay. Thanks for the question. Just give me a moment so I can just go back to that slide.
Yeah.
Okay. So, so in case of normal cells, the synthesis of 5-ALA is negatively regulated by heme. So heme would inhibit the enzyme ALA synthase, and then this would in turn lower endogenous ALA production and hence would lower PP9 production and heme production as well. So excessive production of PP9 or heme is really dangerous. It's harmful because excessive PP9 levels will lead to porphyria, like erythropoietic porphyria. It's a kind of skin disorder. Or excessive production of heme will lead to oxidative stress or oxidative damage in the body. So in order to prevent this, the heme biosynthesis pathway is tightly regulated by heme itself. But in case of tumor cells, what happens is that the ferrochelatase enzyme is either downregulated or its activity is decreased, due to which the conversion of PP9 to heme is prevented, and that's the reason why high levels of PP9 will build up. And the second mechanism in tumor cells, like leading to preferential PP9 accumulation, is increased enzymatic activity. So, increased enzymatic activity of any of these enzymes in the pathway will result in increased PP9 buildup. And again, that's what we desire. We want high PP9 levels in the tumor cells so that they can lead to ROS mediated cell damage. I hope I answered your question well.
Yeah, thank you, Ayushi. The next question is, uh, how to know what guidelines should we consider while selecting the cell line for targeting the cancer? What parameters should we focus?
Okay. Okay. So, as far as my research was concerned, we ended up choosing glioblastoma because it's highly heterogeneous. And it's one of the heterogeneity is one of the causes of resistance. So we wanted to deal with heterogeneity. We wanted to explore various mechanisms that are responsible for heterogeneity. So we initially screened various cell lines like pancreatic cell lines, lung cancer cell lines, skin cancer cell lines, and finally this glioblastoma cell lines. And we found that U118s were highly heterogeneous. So we actually saw like two PP9 fluorescence peaks that we were able to generate or derive from the flow cytometer. So there were like two peaks, one at low PP9 fluorescence and one at high PP9 fluorescence. So that's how we came to know that this cell line is heterogeneous. And then we ended up separating the low PP9 population and high PP9 population. So we can actually determine the mechanisms underlying low PP9, specifically in low PP9 population.
Thank you, Ayushi. One more question is there from Tejas Hire. Okay, I will show you the question. How long should a patient wait after 5-ALA administration before the surgery or the diagnosis?
Okay, so it's usually 4 hours, and that's optimum because it usually takes 5 ALA 4 hours to get metabolized to PP9. So that's 4 hours before surgery.
Okay, thank you so much. Uh, I would like to ask one question, Ayushi.
Yep.
As you have discussed the fluorescence based cancer detections and all, but what are the limitations detection.
Sorry, you were stuck.
Okay, okay.
Yeah. Can you
Am I
repeat your
audible?
question? Yeah.
Yes. Could you please explain what are the limitations of fluorescence-based cancer detection?
Uh, so again, I'll go back to resistance. Though it's clinically successful, 5-valent PDT has been clinically successful, and it has been one of the like breakthroughs in cancer treatment. It does carry some drawbacks like resistance. So far, PP9 heterogeneity, ABCD2 mediated PP9 efflux, and there are some other factors as well contributing to resistance. So those are the major limitations. Like PP9 heterogeneity is the major limitation that we are dealing with, and that's actually the breakthrough part of our research, like in the lab.
Thank you. Thank you so much. Uh, yes, I guess there are the yes, we have covered all the questions now. It is actually a very admiring and outstanding research was what you have done. I extend my sincere thank you for your sharing for your expertise in your research work. So she shares the how fluorescence-based technique plays a pivotal role in modern cancer diagnosis by enabling the sensitive real-time visualization of cancer cells, biomarkers, and tumor microenvironments. She has done a very extensive work on cancer treatment. Really, it's outstanding, Ayushi. Basically, she has emphasis on the glioblastoma, multiform, and again biosynthesis pathways. So, thanks once again for sharing your research work as well as insights on your research work. Thank you, Ayushi.
Thank you so much.
Uh, so, please accept this certificate of appreciation as a token of love from our college.
Thank you so much.
Thank you. We would like to invite you again for your end up of the research, what you have results and the topics what you have done. Again, we will see in the next sessions. Thank you, Ayushi. So we will move to the second session. Thank you, Ayushi. You can leave this stream.